My screen shared.
We are live.
Hello, everybody. Good morning, good afternoon, good evening in the different parts of the world that you may be. This is the International Ophthalmic Conclave organized by the AIOS. And it's an absolute pleasure that we are with us. We have a wonderful partner with us for this meeting, the Asia Pacific Strabismus and Pediatric Ophthalmology Society. The president, Professor Frank Martin, and the Secretary General, Dr. Jason Yam, who kindly consented to hold this meeting, this discussion on myopia and focus 2025, an extremely important issue that is affecting the entire world and probably is an epidemic and a major concern all over the world, including in areas like India, where still some time back we were not so very concerned about it. But the massive increase that we are seeing in our young children is definitely a cause for concern. And again, I thank the APS-POS for helping us organize this session on this extremely important topic. I will introduce Professor Frank Martin, who really needs no introduction. He's a world-renowned pediatric ophthalmologist. He's the president of the APS-POS, the Asia Pacific Myopia Society, past president of the International Strabismology Association, and the IPOS. He's a clinical professor at the University of Sydney and chairman of the Children's Medical Retina Institute. He has massively contributed to pediatric ophthalmology both nationally and internationally. He is a part of a number of AAPOS committees. He has been the president of the Royal Australian and New Zealand College of Ophthalmologists in 1997 and is also a member of the board of the American Academy of Ophthalmology. So it's a great pleasure and an honor to have Dr. Frank with us on this meeting. I also take the pleasure to welcome the Secretary General of the APS-POS, Dr. Jason Yam, who is a professor at the Department of Ophthalmology and Visual Sciences at the Chinese University of Hong Kong. He serves as the Secretary General of this APS-POS, Training and Education Committee Chair of the International Pediatric Ophthalmology and Strabismus Council. He's a council member of the Asia Pacific Myopia Society, Society Relations and Leadership Development Committee of the International Council of Ophthalmology, Public Education Standing Committee Secretary, and Ophthalmic Education and Standing Committee and Research Standing Committee of the Asia Pacific Academy of Ophthalmology. Many other international academic positions, which probably because of shortage of time, I will not be. So again, welcome, Dr. Jason. I would request Dr. Frank to say a few words before we start this session. Dr. Frank, please.
Thank you very much, Rohit. I was thinking today, what will I talk about? Well, I started to think back when many years ago, at the age of 14, I was diagnosed with myopia. I was the only child in my class with glasses. Today, you go into a classroom of 14-year-olds and more than 50% of them are wearing glasses. They're myopic. So this condition has changed. In my training, refractive error was just something very minor that we didn't worry too much about. But today, myopia has become a very important disease because we know the long-term implications. As ophthalmologists and orthoptists, we're in a very privileged position that we can give advice to our patients using science, evidence-based, and not be in any way influenced by commercial aspects, which some other professions are. When looking at today's program, we will learn a lot more about how the prevalence of myopia, what can be done to prevent it, and the treatments that are now available to slow progression. So thank you very much for inviting the Asia Pacific Society of Pediatric Ophthalmology and Strabismus to participate in this very important conclave.
Thank you, Dr. Frank. Dr. Jason, a couple of brief comments before we start the program.
Thank you, Rohit, and
Hello, everyone. It's our great honor for APSPOS to conjoin this session, which is an extremely important session that we can bring over various expertise to talk together how to manage the myopia from different regions. And I look forward to hearing all the inspirational talk, and I hope that we can have more exchange. Thank you very much.
Thank you, Jason. We'll now go on straight to discussing how to first prevent myopia before we go on to talk about preventing its progression or managing the progression. So we'll have Dr. Amanda French, who is the associate professor and an epidemiologist who works in the area of myopia development and children's eye health. She's an academic and a researcher at the University of Technology, Sydney, where she currently heads the Department of Orthoptics and has a lot of work in myopia and prevention. So it would be wonderful to hear her talk on public health approach for myopia prevention. Dr. Amanda, please.
Thank you very much to the organisers for inviting me to speak today. I will be talking about public health approaches to myopia. So there has been rapid increases in the prevalence of myopia across the world in recent decades. And what we're really seeing now, especially in urban East Asia, is that there is an epidemic of myopia. There have been some projections that have suggested that worldwide we're looking at a prevalence of myopia of 50% of the total population by 2050, which is quite significant. And the big problem here is that as the prevalence of myopia increases, so does the prevalence of high myopia, myopic pathologies, and non-correctable visual impairment. So in terms of public health approaches, we're looking at quite a serious issue here that we would like to prevent. So we're wanting to understand really the modifiable risk factors that we could use to prevent the onset of myopia, delay the onset, and then reduce the progression of myopia to prevent those myopic pathologies. So what do we know so far about environmental factors and how they impact myopia? The first observations were that children who were going to school, particularly for many years of schooling and high intensity schooling, were more likely to be myopic. You can see this is some data from the Sydney Myopia study here, where the children who were in academically selective schools or streams had a significantly higher level of myopia prevalence than those in general schools. So there were two ideas that came out of this association between education and myopia. And the first was that maybe near work is important, and that does appear to promote the development of myopia. The other idea was that children who were spending more time absent from school and less time exposed to artificial light and more time outdoors were protected from myopia development. With some further investigation into this idea, it was shown that children who spent more time in outdoor sports were less likely to be myopic. And this led Rose et al. To look into time outdoors and how that relates to the prevalence of myopia. And this classic figure that a lot of people will have seen from the Sydney Myopia study that shows that children that had low time outdoors were at significantly greater odds of having prevalent myopia. And when high time outdoors was spent, they had lower odds of myopia, even when they were doing higher levels of near work. So some really important ideas from this study were that this was related to the outdoor environment and not outdoor sports, because outdoor leisure time, when you're having picnics and spending time outside, not doing sports, were also protective for myopia development, but indoor sport was not. So we knew then that it wasn't related to the activity that was being performed, but the outdoor environment itself. There's been several meta-analyses outdoors and prevention of myopia. So the Sydney myopia study that I was just talking about was a stratified random cluster sample of children in 2 age cohorts. They were 6 years and 12 years. And we followed them up again 5 to 6 years later when they were 12 and 17 years as part of the Sydney Adolescent Vascular and Eye Study. And from this longitudinal data, we can see that, again, there's really significant relationships between time outdoors and myopia, with the children that spent low time outdoors at significantly greater risk of developing myopia by follow-up. So this was showing a causal link between low time outdoors and myopia development. So there have since been some intervention trials. So the GOALS study in 2015 showed that a additional 40 minutes of outdoor time per day was related to a 25% reduction in incident myopia. And the ROC study in Taiwan showed that with an increase of 80 minutes per day, there was a 50% reduction in the onset of myopia, and that was only over a 1-year period. So that was really clearly showing that time outdoors being increased as an intervention was effective for reducing the prevalence of myopia. Again, in Taiwan, this is in preschool children, they were increasing the time spent outdoors by 2 hours per day. And what they found was that they were able to reduce the prevalence of myopia, and that then plateaued and was kept stable over a number of years. And also in Taiwan, this is an extension of the ROC program that I was talking before, where they increased time outdoors by 120 minutes per day instead of 80 minutes. And what they were able to do was show that this upward trend in myopia prevalence that had been going for many years was starting to reverse then with that increased time outdoors. So what is the role of near work then? We can see that time outdoors offsets the role of near work in promoting myopia development. And there's been lots of extensive investigation into near work as a risk factor, which has shown largely inconsistent results. However, a meta-analysis in 2015 did confirm that time in near work increased odds of myopia by an odds ratio of 1.14. And for each additional diopter of near work, the odds increased by 2%. However, we don't know what the mechanism is for near work and how it might be promoting the development of myopia. There's been many things that have been investigated, like accommodation. However, none of those have seemed to pan out. So with increasing use of digital devices in recent years, there's also speculation that they may be important for myopia development. However, studies investigating screen time and myopia directly have had, again, inconsistent and largely negative findings. This is some data from our study which looked at different types of near work and which ones might be associated with myopia. And near work overall and paper-based near work, particularly homework and reading, were more related to myopia than screen time was. However, computer time was more in myopic children when they were older. So the relationship between screen time and myopia doesn't appear to be clear, and while it might be adding to the amount of time in near work, it doesn't seem to be an independent risk factor on its own. So coming back to the idea of time outdoors, how do time outdoors and near work relate to each other? One of the early things that people started to say about mechanisms for time outdoors was that, well, if children are outdoors, then they won't be doing as much near work, and maybe that's why time outdoors is protective. But what we see is there's a very low correlation between time spent in near work and time outdoors, and there's a significant proportion of children that spend high time in both near work and time outdoors, or low time in near work and time outdoors. So that's implying that there isn't a substitution effect for these two risk factors. They are working independently. Near work to promote myopia development and time outdoors to reduce myopia development. But there is an interaction between these factors. In this data, we can see that the children who were more hyperopic tended to balance their time spent outdoors and near work. If anything, they were doing more time outdoors than near work outside of school hours, whereas the children who were more myopic were spending much more time in near work than outdoors after school hours. So this is implying that if you are spending high time in near work, you need to be doing a high amount of time outdoors to counteract the negative effects of near work. So having that balance between these two factors seems to be important. So in terms of mechanism, what is the mechanism if it's not that children are doing less near work when they're outdoors? The original hypothesis put forward by Rose et al. in 2008 was that when you have high light intensity outside, it leads to the release of dopamine, and that is a known inhibitor of eye growth, therefore preventing the development of myopia. This has been supported by animal studies. What we have found in human studies is that it's definitely not related to UV exposure or vitamin D, and that means being outside while still using sun protection is appropriate. And a more recent theory was that higher spatial frequency of scenes when outdoors might be important, but that is still undergoing investigation. So how much time outdoors do you need to prevent the development of myopia? The epidemiological studies suggest approximately 2 hours per day or 14 hours per week is needed, but there is a dose-response relationship where the more time outdoors you spend, the less there is myopia incidence. There's less myopia onset. So you do need a fair bit of time outdoors to be able to prevent myopia development. The other thing that's important to think about is the high light intensity that's needed to stimulate the retinal dopamine release. And animal studies suggested around 10,000 to 20,000 lux, which is easily achievable outside. However, the human studies suggest that more like 2,000 to 5,000 lux is sufficient for retinal dopamine release. And this is achievable outside, even in a shaded area. So you don't need to be outside in the middle of the day in direct sunlight to get these levels. And the other thing to think about is that each time you go outside, retinal dopamine is released, and that has the inhibitory response. And after that, the retinal dopamine release plateaus. So there is some evidence that having intermittent exposure to high light intensity is more important or more valuable for myopia prevention than having extended periods of exposure. So does time outdoors reduce myopic progression as well? We've got some evidence that time outdoors does change eye growth. Some of the early evidence was that eye growth changes by season. So in the summer, when more time outdoors is spent and less near work as well, there's less eye growth than in other months. And you can see here, this is a comparison between Sydney and Guangzhou, that there is a difference in the progression rate for children with myopia in those two locations, indicating that there is some impact of lifestyle and location or environment. In our data, we can see that time outdoors does definitely slow eye growth on a population level. So children will have less spherical equivalent refractive change and less axial elongation when they're exposed to high time outdoors. What we see in myopic children at baseline is that these trends are still present, but they don't reach statistical significance. And this has been a problem across many studies that have investigated time outdoors and myopic progression. We think one of the key reasons here is that with myopia, and therefore it's difficult to get that variation in time spent outdoors. We also have a small number of myopic children, particularly in our younger cohort, which makes it difficult to reach statistical significance. And the other possibility is that time outdoors is more effective on children who are not myopic, so preventing the onset of myopia rather than changing the progression afterwards. And just lastly, before I get to my concluding slide, I wanted to mention that there was significant impact of the COVID-19 lockdown periods in changing children's behaviours, with much more time spent on devices and in near work and less time outdoors. And what we saw with this was an increase in both prevalent and incident myopia after these lockdowns. And this was even for children who were undergoing acts during the pandemic period and during those lockdown periods. Something that was important was the Mosaic study showed that children who were using low-dose atropine had no treatment effect during the lockdown period, but children who were recruited after that lockdown period did. So this implies that time outdoors may be important for also the efficacy of pharmacological treatments. So increasing time outdoors is an effective public health strategy. Outdoors and near work is quite important, with at least 2 hours per day of time outdoors recommended. And time outdoors may also help with myopia progression and treatment efficacy. Thank you very much.
Thank you, Dr. Amanda, for a wonderful coverage on how we can prevent myopia from developing in our children, and of course how we can prevent. And I think it's something that I've been saying for quite some time now. Myopia is the youngest lifestyle disease in humans, and just like we cannot advise management of diabetes without controlling the carbohydrate or the sugar intake, I think that while evidence keeps accumulating, I think that we need to reinforce the lifestyle change, which is kind of like, absolutely changed post-COVID. Get back that previous lifestyle that children had. Of course, you can never get back or reverse the time, but at least get the importance of, as you mentioned, the outdoor activity and controlled indoor activity, balancing both indoors and outdoors so that we can have a net protective effect of the outdoor activity. I'll just take a quick comment from Jason, or anybody wants to say anything. Otherwise, we'll go on and I'll probably run through the speakers before we have some comprehensive discussion on this. Maybe we'll go on to our next speaker, who is Dr. Jaspreet Sukhija. Dr. Jaspreet will be speaking on pharmacological management of progressive myopia. And Dr. Jaspreet is a professor and heads the Pediatric Ophthalmology and Strabismus section at the Postgraduate Institute of Ophthalmology and Research at Chandigarh. And he has numerous research and a great interest in myopia and, of course, in pediatric cataracts. Today, we'll have his experience on the pharmacological management of progressive myopia. Dr. Jaspreet, please.
Thank you so much, and I'm honored, and it's a great opportunity to be a part of this program. Thank you, the Asia Pacific Pediatric Ophthalmology Society and AIOS, and thank you, Dr. Frank Martin, Jason Yam, and Dr. Rohit Saxena. I would be speaking on the pharmacological management of progressive myopia. Now, as we know, there are different ways to control myopia. It's an epidemic. It's almost like a pandemic, and we know that it's going to double by the year 2050. So what are the ways we can stop its progression? Well, environmental modification, as has been discussed, is one of the important ways to go about it. But along with that, you have pharmacological therapies, and then you have optical corrections. So it's a combined approach which will help in prevention the progression of myopia. So I would be speaking on what we have in the pharmacological section. So many trials have been done here, and the role of atropine has been well established now in delaying myopia progression, but there is no consensus on its concentration. And even though the mechanism is not well understood, it still is working with good efficacy. So other drugs under evaluation are like pyrenzapine, which has been tried, had a lot of systemic side effects. Then you have dopaminergic drugs. We do not have human studies for them. You had anti-inflammatory drugs like ketorolac and cyclosporine have been tried. No human data available. IOP lowering drugs, again, a suggestion was made. based on that the raised IOP accommodation induced myopia, but we don't have any human data. So what we have data for is atropine, and the most widely used drug with a concentration of 0.01%. There are higher concentrations also which have been used, and some of them have been studied from 0.025% to 0.1, 0.5, and 1%, which is the highest concentration. So as you can see here, what happens is, these are the RCT network plots. And if you see, the maximum studies, the maximum RCTs have been done with 0.01%. That is what we have data for in terms of annual refraction, as well in terms of axial length growth. So it's 0.01% which has been studied most widely till now. So how to select the ideal concentration for clinical use, considering that we have so many concentrations available in the market? So first and foremost, should be effective in slowing myopia progression, should be well tolerated, free from side effects like photophobia, near vision difficulties, and of course should have minimal rebound myopia on stopping treatment. That's very important. So coming to some of the initial studies which were done, like 1% atropine, it was the first randomized trial was done in 1989, and they had a follow-up of 1 year. Although they had good efficacy, but there was a high dropout rate because of side effects of photophobia. And that is one of the most important things to see when you're prescribing these drugs. Then after that came a little lower concentration like 0.5, 0.25, and 0.1%, where some RCTs were done. And one of them had a duration of 2 years, and they found a dose-dependent decrease in myopia progression. The side effects were much more in 0.5%, close to a range of 22%. However, there was no placebo group and there was no axial length data at that time. Then there was a lot of studies and a lot of data which has come out on 0.01%, probably one of the safest concentrations of atropine, which has been found effective in decreasing the progression of myopia. So we had this ATOM 2, probably the first studies which came out were from Singapore on the use of 0.01% atropine, where they showed good effect. We had the LAMP study where they compared different concentration like 0.05, 0.025, and 0.01. Then we have the JAMP study using 0.01 and 0.02% atropine. And then we had one of the Indian studies by Rohit here, a multicentric randomized trial, which shows a reasonably good efficacy. So what happened with this study, which was, I'll just quote some of the recent studies, and this is one by Rohit here, done last year. Basically, what the earlier studies had found was a rapid progression, that means more than one diopters in the ATOM 2, close to the range of 18% at 2 years. And LAMP had a progression of about 28% at 1 year. So these are rapid progressors. And considering the Indian scenario, at 2 years after starting treatment, there was mild progression in 87%, a moderate in 9%, and severe in just 2.6%. Whereas 17.4% reduction was seen in rapid progressors within 2 years of atropine therapy. So it really worked well in an Indian scenario. Now, why low concentration atropine may work better in Asian children than white children? Well, few of these studies, like we have the Asian studies, have reported good outcomes, whereas in the Western population, they haven't found a significant result. Maybe one of the reasons is that atropine binds to melanin. So maybe darker irises have result in slower release because of good binding and a longer active time for the drug, which may yield higher efficacy in Asian children. So after that, now they were rapid progressors. Now what happens to them? How do we treat them if we have to treat them pharmacologically? The use of maybe higher concentration atropine? Well, yes, the LAMP study was one where they did a comparison of 0.01, 0.05, 0.025, 0.01, and a placebo group. So that's important to have a placebo group along with that. They gave these drugs for 2 years. And after that, what happened was in one of their group, randomized into a continued treatment group, and the other one was a washout period. So in each concentration, they had a continuous treatment group and another washout period. And of course, they studied the results at 4 years, having about, you can say, 269 children. And what they found was that children who needed to restart the treatment were almost similar in all the groups, in 0.05, 0.025, and 0.01. And so they found that retreatment was associated with a younger age, but not with atropine concentration, sex, or baseline spherical equivalent. And what they found was a dose-dependent effect. Now, compared with placebo, axial elongation was slowed in a dose-dependent manner, the highest efficacy being with 0.05, that is a higher concentration. And similarly, the myopia progression decreased in a concentration-dependent manner, again, with the higher concentration showing a maximum decrease in progression. So 0.05% was effective with good tolerance over 5 years. And they said it should be continued for 5 years. And accommodative amplitudes and photopic mesopic pupil size was almost same across all group. But the issue is they did find that treatment was going on, but now what happens if you stop treatment? Haven't measured the rebound as yet. So considering 0.01 and 0.05 in their group, it was again a concentration-dependent effect where they found that almost a 67% reduction as compared to 27 in 0.01%. And similar was a significant decrease in the axial length progression. However, the side effects were much more. So the another study with using the higher concentrations of 0.1 and 0.5% was the ATOM-2, the extended study, where they stopped treatment with all these three concentrations at 2 years. That was the washout period. And what they found was a greater rebound effects with the higher concentrations. And when in the year 4, when they started all these patients on just 0.01, so all these concentrations they were stopped, and then every one of them was given 0.01. And what they found in year 5 was that those who had initially started on 0.01 had the lowest overall refractive progression. And so they concluded that 0.01 was clinically more palatable. And again, one of the important studies with a higher concentration, again, Rohit has published this, or maybe going to be published in this issue of Indian Journal of Ophthalmology. Of course, 40 children were there who had a progression of 0.05 diopters in the preceding year. Of course, these were the children who did not receive any atropine. They were naive patients. And they were given point. And a significant reduction in myopia progression rate of -0.4 plus -1.4 diopters was seen with 0.05%. And they found it a really significant effect. So they found a significant reduction in axial length progression as well. There was no correlation in axial length and spherical equivalent progression, what they found. And the response to treatment was independent of the age at baseline, a baseline refractive error, a baseline rate of progression, gender, and a family history of myopia. They did not find any significant side effects. The other study which has used 0.05% is this mosaic study where they use different concentrations. And in their extended study, in the placebo group, where finally atropine 0.05% was given for 1 year, they exhibited a 0.13 diopters less myopia progression and a 0.6 millimeters less axial elongation compared with the placebo group. The side effects were tolerable. The rebound has not been studied as yet, but atropine was given after the placebo. So that means after 2 years of placebo. So the effect of age could also have a role in decreasing myopia progression. So coming to the meta-analysis, which was done on 19 studies, almost about, you can say, 3,000 children, where they found atropine to be effective in slowing myopia progression, there was no difference in efficacy with different doses of atropine in their study. Higher doses, however, were associated with more adverse effects. Now, because adverse effects were less frequent at lower doses and higher doses were not more effective, this meta-analysis supports use of atropine at low dose, that's 0.01%, to reduce progression of myopia. So this is just the WHO guidelines, which they were earlier. Obviously, things have changed now because of higher concentration, fast progressors, rapid progressors. Things are changing, and we need to rethink about these guidelines, where they found that, of course, give treatment for 2 years with 0.01%. If you have a good response, you can taper and stop. If you have a moderate response, probably continue for 1 to 2 years and then taper and stop. Now, these poor response, obviously, they did not have any answer to that. Consider taper and stop atropine, but there are a lot of other interventions available now. So coming to just before I come to
exceeding time.
Yeah, just before I conclude. So coming to what's the ideal concentration to be used? Well, we have 1% effective, but bothersome side effects, 0.5 and 0.1%. Again, very effective, but rebound myopia and side effects are a concern. 0.05% effective, but we don't have data on rebound myopia. And so what we remain with is 0.01%, which is probably the most effective concentration in 5 years. These state of rebound myopia and minimal side effects. So how to taper? Well, there are no guidelines. Probably maybe just thrice a week, twice a week for a couple of months and then taper it. And so I'd like to conclude here by saying that probably 0.01% is the only approved drug till date for myopia control, which is well researched, with known efficacy, with negligible side effects, works well in the Asian population, is a cost-effective treatment without significant rebound. However, we need customization for poor responders to 0.01% and maybe use higher concentrations for rapid progressor. Thank you.
Thank you, Jaspreet. Very comprehensively summarized the various options that have been tried for atropine. As you mentioned, essentially 0.01 is commercially available in most places, many places all over the world. 0.05, of course, looks very exciting based on some of the research that has been going on. We hope that we are going to be able to get access to commercially available 0.05 atropine soon. And then probably we will be in a better position to give our experiences in India. So till that time, of course, I think we have a lot of questions to discuss, but let's run through the talks before we discuss this. So next, I will be inviting Dr. Jitendra Jethani, who will be speaking on efficacy of myopia control spectacles. Dr. Jitendra is a pediatric ophthalmologist practicing at Baroda Children's Eye Care and Squint Clinic at Gujarat. He's currently doing his PhD in myopia progression in children. Not only currently, but he has a huge number of publications, more than 70 indexed publications, and more than 200 research papers to his credit. So Dr. Jitendra would be speaking on optical interventions for myopia.
Thank you. Thank you so much, Rohit sir, for the opportunity. As you said, I will be speaking on efficacy of myopia control spectacles. Am I audible? Slides are visible?
Yes, sir, you're audible.
Okay. So broadly, beyond genetics, the broad key factors for myopia progression is now thought to be it was altered dopamine release, outdoor sitting, and we heard two preceding talks on environmental modifications and by Jaspreet on atropine. So there are two theories. One of them is peripheral hyperopic defocus, which essentially means that it is the parafoveal, or rather paramacular area, which is responsible for the axial elongation. And then there is another theory where high contrast stimulating bipolar cells have been implicated for the eyeball growth. And so this the first theory basically originated from these beautiful articles by Earl Smith III, which started in 2007 and continued till almost 2016. There were multiple publications on the effect of foveal ablation on emmetropization and on form deprivation amblyopia. Basically, what he did was, or rather his whole group, what they did was that they ablated the fovea, and then they tried to see whether there is still ocular growth or not. And then they optically also imposed defocus, and they found that it can actually alter the shape of the eyeball and the pattern of this is basically secondary to the peripheral refraction. This was done mainly in infant macaque monkeys. And so they tried to show that it was the optical defocus in primates which actually dominated the growth of the eyeball. And so this is one of the pictures taken from their article where they show that this is the control eye, and this is the treated eye where they tried to do a peripheral hyperopic defocus. And by doing that, they could show that there was some elongation. And how the glasses work are by the fact that they actually create a myopic defocus. So there are plus lenslets plus lenses in the periphery. So the central area is around 9 millimeter zone. And depending on which particular glass, so there are three major industries which are into it. Hoya, DIMS by Hoya, which is defocus incorporated multiple segments. So the central part of, there's a clear 9 millimeter zone. And this is surrounded by almost 9 rings of, or rather 9 hexagonal rings of plus 3.5 diopter, which create myopic defocus. So so their refractive status is plus 3.5, and this creates a myopic defocus, which means that it creates a peripheral defocus, which is anterior to the retina. Now these are polycarbonate glasses, and this is the maximum limit to which the glass power is available. And then there is HALT by Essilor, which is stylist, which is highly aspheric lenslet target. They are basically all the three, the cylindrical annular refractive element by Zeiss. All three of them have almost similar features. And so this is a wonderful article where they have compared these two novel myopia control spectacles, and what they have tried to show is that these are nine hexagonal rings. There are 11 rings in HALT spectacles. Basically, there is a central clear area, and the peripheral rings they help in giving a myopic defocus. So basically, they try to focus the image anterior to the retina. And these are some of the articles which show that both HALT and DIMS do work. Now there has almost been 6 to 8 years of experience, and they have compared both DIMS and HALT, and both of them work. And so our experience has been good with all the three. In our own work, we were using DIMS and then switched over to HALT and CARE also, and all three of them work. They work nicely, and they do. There was a progression before DIMS, and this is the progression after DIMS. So they have a good control in all three. All three spectacles works. So normally there are questions that whether one of the glasses is superior to another. In our practice, we did not find any difference between all the three type of glasses available. This is something which at present is not available in India, but this is a good, exciting technology. Basically, it works on stimulating the bipolar cells. So the theory is that when there is more light on the central cone than the average of the surrounding cones, it stimulates the bipolar cells. And when the surrounding cones have more light compared to the central cone, it switches off the bipolar cells. And by overstimulating of the retina, there is increased bipolar cell activity, which contributes to the myopia progression. And so they have a central 5 millimeter zone rather than a 9 millimeter zone. And so they basically work on reducing the contrast a little bit, but there is good visual acuity, and it is slightly different from the HALT and DIMS and CARE by the fact that they do produce good visual acuity in the center. Even in the peripheral vision is good. It lowers the contrast slightly, but it lowers it uniformly. And there have been some results, not from India, because it is right now not available in India, but they do suggest that it works and reduces the progression of myopia. So in conclusion, we believe that glasses are definitely effective in controlling the progression of myopia in children. Whether they should be used as first line of treatment or not, that's a question that we have to discuss. But definitely there will be a good add-on in the treatment protocol to atropine if the patient is already on atropine. And I think there's a talk after my talk on the same thing. So thank you so much for the opportunity.
Thank you, Jitendra, for very nicely bringing forth the optical options, particularly the spectacles that are there. We did not have too much of a discussion, or maybe we'll take that in discussion, experience in ortho K and multifocal lenses, probably, especially from Singapore and Australia, because in India, there is not so much experience with these options at the moment. But hopefully, there is greater increasing acceptance. Maybe we'll get more information as availability increases. So, but as you've made your last comment, it's like probably combination therapy that we must understand, because a lot of patients do not get controlled on either of the treatments. And what are the options for combination? We have Vian, who's going to speak on myopia control treatment using combination therapy. Dr. Vian is a consultant of cataract, comprehensive ophthalmology, pediatric ophthalmology, and adult strabismus at the Singapore National Eye Center. His research interests include retinopathy of prematurity, artificial intelligence, and blockchain in healthcare, and has numerous publications in both in all these areas that he's working on. So it'll be wonderful to hear Vian on combination therapy.
Thanks, Professor, for the kind introduction. Let me just share my slide. And once again, I would like to thank Prof. Rohit as well as Prof. Jason Yam and Prof. Frank Martin for the kind invitation, and it's a pleasure to be here. So today I'll be speaking on the topic of myopia control treatment using combined therapy. Right, so these are my financial disclosures. Right, so the main thing about the myopia, as we know, based on the trend, the main thing is to actually suppress the overall high development of high myopia. From the current projected 10%, we are hoping that we can actually suppress it lower so that there's actually lower incidence of pathological development in the future years. And this is especially with the publication by Prof. Bullimore, where now every diopter counts, as it has been shown that with every increase in diopter, there's an increase of about 60% or 40%, depending on the denominator, of developing visually significant complications, such as myopic choroidal neovascularization or MMD. And so previously we have the atropine that's been the mainstay of treatment, and then now we have things like contact lenses as well as glasses. So how about combination therapy? And the main thing about each therapy is that they have their own pros and cons, their own benefits as well as disadvantages. So when we look at atropine, it's non-exclusive therapy. Nearly every child can be put on atropine unless there is a development of allergy. And usually in the low dose range, there's minimal side effects, even up to 0.05, and most of them are actually well tolerated. And then comes the contact lenses, where there's actually a strong lifestyle motivation for this, where children usually are those who are in a more active group. They have sports as a core curricular activity, and it has been shown to have actually robust clinical efficacy compared to other forms of modalities such as atropine and glasses. However, there's a need to be cautious because of the need for hygiene as well as for the patient to have discipline. And apart from that, there's also the social as well as cultural issues where there's limited parental awareness in certain regions with regards to the safety and efficacy of contact lenses. And lastly, the relatively new kid on the block as well will be the glasses, which is the myopia control glasses that was so well demonstrated by the previous speaker. However, there's certain issues to this where there's some age dependency, where options like the Care lens is shown to be effective from 6 years onwards, as well as the DIMS and HOP lenses are shown to be effective from 8 to 9 years onwards. Essentially, they're convenient, and however, they are actually very costly. So in terms of a combination, so we are looking at the evidence that's been published over the past few years. This mainly started in 2019. That's about coming to 6 years ago already, right? So the first one was by Chen Zet. It was published over a duration of 2 years, looking at age group 5 to 12 years old. And it's a retrospective one where there's the comparison between using Auto-K as well as Auto-K plus atropine at the 0.01% concentration. And if you can look at this, they started it, the first year was just both, just Auto-K versus the control group. And second year, they added on the atropine, and there was a significant decrease in the treatment group in the second year. So this supports the use of a combination together with autokeratology, which will be a recurrent theme as we go along. Then Tan Q and in 2020, about 5 years ago, again, looked into the efficacy of atropine with autokeratology. This is a 1-year study between 6 to 11 years, so pretty similar age group. And then when they look at it, the AOK is the one with atropine as well as Auto-K versus the Auto-K only group. And it does show a significant decrease in the overall axial length elongation over 12 months. So in this sense, this is again a successful demonstration. However, in 2022 by Erdines, he looked at using atropine 0.01, but this is a retrospective study against myopia control glasses. However, because it is a slightly older study, this is using progressive lenses as well, which we now know that they are not very effective against myopia therapy. And the last one, including a defocus soft contact lenses. And if you look at the right side of the screen, A plus versus A plus PAL versus A plus contact lens, they're actually essentially similar. And in that sense, it shows that even addition of a progressive lens or defocus contact lens doesn't really add much benefit compared to atropine versus that of a control vision as single vision glasses. Again, in 2022, Chen Zet again looked at atropine versus auto-K. As I said, it's a recurrent theme of the combination trials. So over 3 years, under 12 years old, this was a slightly special one where they looked at auto-K poor responders. So those who are already poorly responding to the effects of auto-K, and then they added on atropine 0.01%. And if you look at it, the OK versus the OKA, the OKA is the one with combination of atropine. There's actually not much significant difference over the first, second, and third year, as well as the accumulation of the axial length change. So in that sense, we know that even though auto-K and atropine seems to work well as a combination, those who are already poorly responding to auto-K might not benefit much. Next, in 2022, Shi et al., they looked at again at atropine 0.01 versus auto-K, and this for 2 years within a slightly older age group. And you look at it, there is a marginal significance in terms of the difference. And on the right graph, the B graph, the ACO, which the atropine with the auto-K, versus the auto-K and atropine alone monotherapy, there is a significant decrease. Though, if you look at it, it might or might not be clinically significant. However, it is statistically significant, and we'll take it as a plus. Subsequently, Adines again in the same year, 2022, looked at MySight now. Now we are going into some of the newer proven therapies for myopia control. So this was a retrospective comparison in, again, a slightly older age group, 6 to 16 years old, for the MySight 1-day soft contact lens, again with atropine 0.01%. If you look at it overall, even the first year as well as the second year, there is actually not much difference compared to the control group in terms of the decrease in the overall axial length elongation of the atropine versus the combination group. So in that sense, it's slightly disappointing to see that the combination with the MySight 1-day and the atropine did not really have any significant difference in the combination. And coming to 2023, basically about 1 to 2 years ago, Paulo et al., for a duration of 1 year, looked at also again a older age group. This was a prospective trial looking at the MyoSmart, which is the DIMS glasses, together in combination with the atropine 0.01%. And overall, they found that the atropine plus the DIMS lens actually had the best effect. If you can see, the overall change in axial length is the lowest with the atropine plus DIMS glasses versus monotherapy as well as control. So in that sense, then this is a positive result for glasses with atropine. And same thing, 2023, Tan et al., combination of auto-K versus atropine as well, 2 years, 6 to 11 years old. And this quite clearly shows that the AOK, which is the atropine plus auto-K, has significantly better results versus the auto-K itself. And also compared to the Romeo study where there is control and auto-K single groups. The auto-K single groups, monotherapy groups are actually pretty similar to the study group. So this demonstrates significant efficacy of the combination AOK group. And then there's another win for auto-K. And coming to last year, this is getting more recent already. So Tang et al. Looked at using atropine, DIMS, as well as auto-K lenses as a prospective trial over 1 year, looking at the cycloplegic refraction as well as axial length. This slightly busy slide, but I would like to direct you to the upper right corner where they showed that the auto-K plus atropine is significantly better than auto-K. DIMS with atropine is as superior to DIMS monotherapy as well. So like for like respectively, the combination of auto-K with the monotherapy is stronger than the monotherapy only. However, if you were to look at the nuances, divided by age group, it seems that for the older age group, 10 to 14 years old, the combination therapy has better efficacy. Where you can see in the graph B at the bottom right, the OKA is actually significantly better than the OK group, as well as the DIMS A group is significantly better than the DIMS group. However, this difference was not seen in the younger age group, 6 to 10 years old. So in terms of the treatment, when we select combination therapy, we might have to be cognizant about the selection of patients as well as the age group of the patients. And then lastly, in 2024, Zhang H, something slightly different compared to the previous modalities. They're looking at spectacle lenses together with red light therapy. So this is a prospective clinical trial, DIMS versus DIMS plus repeat low-level red light therapy, looking at cycloplegic and axial length results. And right now, they are currently recruiting, so it's pending, and we look forward to seeing their results in the future to see whether combination of this exciting treatment can have significantly better results. So overall, in terms of combination treatment, as we can see, there's a whole gamut of considerations, things like poor responders, age group, types of treatment that we need to combine. So we still think that combination therapy might be the way to go in future. However, we need increasing data because there's some areas that are still missing. So increasing data will be important for us to drive our decision making. And most of the combination therapy has been based on atropine 0.01, which has been the mainstay. So hopefully in future, we can see various variations in the future. Right. So for future approaches, myopia control glasses, we hope to see more data that pertaining to Hawk lenses, DOTS lenses, as well as the CARE lenses, which has been demonstrated previously. In terms of the myopia control contact lenses, hopefully we can see more soft contact lenses. Currently, there's only one study that is done on the soft contact lenses. And hopefully we can see more that involves the other brands of soft contact lenses as well. And for the atropine, which is the main one for combination, we would also like to see other dosages as well as frequencies, such as 0.125%, 0.05%, as well as those from once a night changing to twice a day dosages. And hopefully from there, we can actually see which might be the optimum treatment, combination treatment that we can select for our patients. And with that, I thank you for your kind attention.
Thank you, Vian, for excellently summarizing the combination therapy that is available to us. And as you mentioned, there is still a lot of data to come in before we can actually understand, particularly the various combinations, the different pharmacological options that we have in various concentrations with the various optical interventions that we have. So great. And of course, you also mentioned the recent ongoing study on red light therapy. So I think that's the apt platform for Jason to talk about red light therapy for myopia control, something that we are hoping Jason, who's trying to lead an international trial, and we hope that India also becomes a part of that. So wonderful to hear early results which Jason has, and of course, hopefully we can be all part of this great international trial to evaluate red light therapy. Jason, please.
Thank you, Rohit. So today I would like to share about the evidence of the red light therapy for the myopia control. Outdoor activity can reduce myopia, especially just now we have heard Amanda's talk about how outdoor activity can reduce the prevalence of myopia. And there is many evidence showing that the increase in outdoor time can reduce the myopia prevalence and sometimes even the progression. And the red light therapy is kind of using in fact, it is using a repeated short-term exposure of low-energy laser. So it is a very, very low-energy laser through the pupil. And it is a home therapy. Home therapy through a machine emitting the red light wavelength of 650 nanometer diode laser and into the eyes. Every day, 3 minutes per episode and 2 episodes with 4 hours apart. And then this is the treatment. And Professor He Mingguan has published the first repeated low-level red light therapy. So the result is very exciting. It is a multi-center randomized parallel group single-blinded trial with 246 children from -1 to -5, and around 120 cases in each arm, control and also the red light therapy group in over 1 year. Here you can see the graph. You can see that, in fact, there is also some axial shortening. That is now we understand more and more results have demonstrated that the red light therapy can induce axial shortening. Around in 20% of them can have axial shortening. And also, if the compliance is good enough, the axial progression can up to 87%. In this this study, the overall average myopia control after 12 months set 76%, because the red light machine can capture the compliance. So if calculating the compliance data for those who are more compliant, the result is even better. And this is a trial that's conducted by Professor Zhao Haidong from Shanghai. This look into the high myopia children. And for these high myopia children, defined as -4 at the baseline. And you can see that from the graph, you can also see that the red light therapy is quite effective in a way. In fact, half of the intervention group can experience axial shortening at 12 months. Here you can see the treatment varies with did not vary with the baseline SCR, and the treatment effect was better in the older children, and this can also improve the untreated, uncorrected vision in the treatment group. Another trial is looking into the red light therapy with combining with the OK lens. This is a trial for those who with OK lens treatment, which is not very in good response, poor responder. And then you can see in this line, in this graph, it is still progressing. And then for those poor responder, randomized into continue OK lens and also continue this is a red light treatment. And then you can see the effect is also very effective. And how about the rebound? After 2 years, Professor He Mingguang has looked into the rebound phenomenon for stopping the treatment. Here you can see that there is a little bit rebound for those who stop the treatment. The rebound did not completely obliterate the earlier benefits. So in fact, for red light treatment, in fact, it also need to be like other treatment like atropine, probably need to wean it off if we need to stop the red light therapy. So rebound is a resurgence of the myopia progression after the discontinuation. And then for red light therapy, the rebound is modest rebound. But if stopping treatment is needed, sudden cessation may not be ideal. Tapering off could be potentially reduce the rebound phenomenon. And we have also conducted a meta-analysis for light exposure therapy, looking into various wavelengths. In fact, the red light is the most effective wavelength that can reduce the myopia progression. And here is also an efficacy meta-analysis of various data suggesting that the efficacy of the red light therapy. Comparing 0.01% atropine and the red light therapy, this is the result. Here you can see that the red light therapy is very effective comparing to the 0.01% atropine. Over 1 year, 0.01% atropine is -6 diopter, and red light therapy is very minimal change. Professor Xu Shun and He Sengui from Shanghai has used the red light treatment for pre-myopia trial. This is they found that for those who have pre-myopia, in fact, the myopia incidence was reduced by up to 55% at 6 months and 33% at 12 months. Because they conduct the study in a school-based setting. So if there is an uninterrupted treatment, because the efficacy of reduction or preventing the myopia can up to 54%. Of course, we all know that the potential safety issue is one of the concerns for the red light therapy. There has been a case report that report the light damage after the red light therapy. And of course, there's many postulation And some suggest Professor Kyokono Matsui from Japan has written a letter to suggest that from the picture, it could be a potential suspected Stargardt case. Of course, we need more data to know that the safety issue about the red light therapy. It could be a potentially photothermal injury from the red light therapy. But however, in fact, when we are now doing the red light therapy, we have several monitoring marker to consider. Number one is the vision. Every time we need to document the vision. Number two, we have the OCT to document the structural safety. And also if they have a prolonged after image, probably it's better to stop the red light therapy if these are some of the marker for safety issue. Of course, other studies have demonstrated that using the ERG machine and then the red light therapy that didn't affect the structural changes. So VA, psychometric reflection, ocular biometry are needed, and also the after image, and we will monitor the after image, and every visit we monitor the BCVA, the fundus, the OCT structural changes for this one. Follow up the first month, and then 3 months, and then every 6 months. And then, so in conclusion, red light therapy is, I would say, one of the very strong intervention measure, can up to 87% control myopia. And in fact, for high myopia, the axial shortening can up to 50% in the treatment group. And the combining with OK lens seems in the poor responder seems to be very effective, can reverse the axial length shortening and also leading to some hyperopic shift. But we need to have a close monitoring to detect very rare complication in some for those super responder. So I would like to let everyone know that the 3rd Congress of Asia Pacific Strategic and Pediatric Ophthalmology Society is coming. It will be in June 29th to July the 1st, 2025 in the Brisbane. So we, on behalf of APSPOS, we would like to invite every one of you here and in the audience to register and then to come to Brisbane and then to join this event. Thank you very much.
Thank you, Jason. I also was supposed to mention this, but great. You mentioned the APS-POS conference in Brisbane. Many of the faculty here are probably already speakers there, so it's going to be wonderful. And I hope many of the audience who are listening would enjoy attending Brisbane, the conference, and the wonderful place that is there. So it would be wonderful, I'm sure, for everyone. And I'm sure there are a lot of questions about the red light therapy, and we'll take them after we have this final talk by Lilian Fu on the guided clinical framework for myopia management. Her primary area of specialization is myopia, refractive, and cataract surgery, and she's a consultant with cataract and comprehensive ophthalmology department and myopia program lead at the Singapore National Eye Center. She is the first fellow, myopia fellow in the whole of Singapore, and is based at the Singapore National Eye Center and is majorly working in managing progressive childhood myopia. So it would be a pleasure to hear Lilian on a clinical framework for myopia management.
Thanks, Prof. Rohit, for the kind invitation as well as the very kind introduction. Also, thanks to Prof. Jason Yam for inviting me to give this talk today. So these are my financial disclosures. So we do understand that axial elongation is a problem with increasing prevalence, and estimated that 10% of the world's population will be high myopic by the year 2050. And this axial elongation, high myopia, would lead to complications such as glaucoma, retinal tear and detachment, as well as myopic macular degeneration. And the risk is significantly higher compared to patients who are lower myopic or even non-myopia at all. So as we all know that based on several studies, the risk of myopic macular degeneration, the prevalence ranges from 8.7% in some studies up to even 65%. And risk factors comprise of age, spherical equivalent, as well as axial length. So previous studies, we understand, were recruited in the 1990s, even up to the year 2000s. And these are older population studies. What we want to know is what is the current day and age near to 2020s? What is the prevalence of MMD and the risk factors? And the myopia onset, we all know, is getting younger, and we would like to study an updated cohort. So we collaborated with the IR, with Singapore Eye Research Institute, to run this high myopia adult cohort study where we look at community-based high myopia individuals. The enrollment period is between 2021 as well as 2023, so it is quite recent. And the criteria to be included needs to be at least -5 diopters and excluding any other pathologies. Location where patients were recruited were in the Hunan province at the Changsha Eye Hospital. Investigations performed in this study include cycloplegic refraction through autorefraction, and the axial length were measured with Lenstar as well as IOL master, and fundus photography were also taken to grade the myopic macular degeneration. So in grading, the trained mask grader were compared with a trained retina specialist, and they are highly correlated, and is classified according to the International Meta-PM classification, where MMD is positive when it is either category 2, 3, or 4, or with any plus lesion. There's also questionnaire administered for risk factor assessment. So what do we found? We found that patients who are aged 40 and above, as well as have spherical equivalent of at least -8 diopters, an axial length of greater or equals to 26.9 millimeters, they have higher percentage of having presence of myopic macular degeneration. And in terms of odds ratio, we found that for spherical equivalent, the odds ratio is 1.7 per diopter, as well as axial length with odds ratio of 3.6 per millimeters, based on multivariate analysis. So looking on the left-hand side is the spherical equivalent as well as the percentage of myopic macular degeneration. We found that in patients who are better than -6 diopters in terms of myopia, there is 0% of myopic macular degeneration, no occurrence. And on the right side shows the graph bar chart for axial length. Similarly, patients who have axial length of lower than 25 millimeters have 0% of myopic macular degeneration. So how does this translate into clinical practice? These studies have its own limitations, which includes selection bias who are non-responder, recall bias because we have questionnaires and they are based on self-reported, as well as this is a currently cross-sectional data and a snapshot of a longitudinal follow-up. So we would like to look at this cohort later on as we follow them up closely. So as discussed earlier, what is the implications of this study? This study allows us to perform risk-based myopia management. So we comes up with 3 thresholds. Firstly, safety threshold. So in patients who are -6 diopters or better, or 25 millimeters or better in terms of axial length, the risk of myopic macular degeneration is 0%. The at-risk threshold is when they reach -10 diopters, or 27 millimeters, where 10 to 20% of these subjects will have myopic macular degeneration. And the high-risk threshold is once they hit minus 14 diopter or 29 millimeters in terms of axial length, where 7 in 10 of these subjects is likely to develop MMD. So previous speakers have mentioned about the various myopia control treatment comprising of atropine, myopia control glasses, red light therapy, and even combination therapy. So how do we justify what do we utilize or what do we recommend to treat clinically for these patients? So let's go through clinical cases. First, we have a 7-year-old Chinese new to the clinic and parents have high myopia. Would like to consider myopia management. So in this child, as you can see, the right and the left eye is -1 as well as -1.5 diopter respectively in terms of cycloplegic refraction. Axial length is also about 22.5, 22.8 millimeters. Patient is currently, if you look at the bar below, in the safety threshold. So good safety margin, you can consider starting monotherapy. All right, be it whether you want to start on atropine or myopia control glasses or red light therapy. So next, we move on to a 9-year-old child coming in, myopia progression despite on low dose atropine 0.01%. Would like to control the myopia better. So what is the child's situation? Right eye is -5 diopter, left eye is -5.5 diopter. Patient's axial length is 24.5 on the right and 24.8 on the left respectively. Patient is nearing the at-risk threshold and hence minimal buffer at this point in time. So we could consider either increasing atropine and or institute combination therapy with optical myopia control such as myopia control glasses, myopia control contact lenses, or even red light therapy. And lastly, in a 12-year-old, high myopia in both eyes and parents are really worried. So what is the status of this child? This child is -10 diopters and that's why parents are worried almost in both eyes. Axial length of 27.5 on the right and 27.8 in the left. Patient is now at the high risk threshold, borderline, at risk to high risk already. All right. Would like to suggest to increase atropine as well as combine therapy. Because with this rate that the patient is progressing, it is moving on to high risk threshold in no time. So I'd like to thank everyone for your kind attention and hope this study gives a guide to how you can potentially apply all the various myopia control in your clinical practice. Thank you.
Thank you, Lilian. That was an excellent explanation. What is the way to identify at risk and weigh treatment options? Because sometimes we get pressurized by parents who are extremely anxious in the very first go, and Dr. Google has told them all the possible problems that high myopia can be, and the child is just at the beginning of his journey of myopia, and yet they are like pressurizing us that why don't you add optical to pharmacological, and why don't you start multiple therapies? And I think it's very, very important that we place the child in the very appropriate at-risk category and explain to the parents how gradually we should work towards managing and understanding at the rate of progression of the child and the risk categories, and therefore intervene accordingly. I think that is a wonderful point you've made for all of us to learn, that just because options are available, not all of them work, and you need to evaluate a child and tailor make the intervention options depending on the affordability, the compliance, as well as the at-risk category. So I think we've had some great talks. It would be wonderful to open up now for questions. I'll just start off with Jason, because I think our understanding of the red light therapy is minimum, and it would be great for us to learn a little more before we go on to the more widely experienced interventions and, of course, risk categories. So, Jason, there is a doubt about the side effects or the adverse events were related to the laser, whether it was appropriate or it was higher than the threshold or something. Are there multiple machines in the market, some of them which may not be proven as far as safety is concerned?
There is some regulation standards, I would say, from the America and also from the laser safety, and of course, there is also many different machine available. Some is using power LED lights, some is using laser. As far as the evidence so far is concerned, only using diode laser to be effective, but not the LED light as far as the evidence is known. So now the point is how we can have minimal energy of the laser that diode laser red light therapy that can induce optimal the effectiveness.
Okay, great. So anybody has any questions can just raise hands and we can move there. Any comments to make, Professor Frank? We can, take some comments from Dr. Frank before on all the talks that have happened, and before we move on to discussion. We have about 15-20 minutes for discussion. So Dr. Frank, first on the symposium and any thoughts?
Thank you very much, Rohit. I think it's been an amazing symposium, all such balanced talks, giving your experience. I still think a lot of it comes down to affordability, because I know the cost of the glasses, the myopia control glasses, certainly in Australia, is extremely high, and most patients simply can't afford them. I don't know what the situation is in Hong Kong and Singapore. In India, I know it's an issue also.
Thank you for Martin. For example, for the cost effectiveness, in fact, we have published a paper in the German Narrow Open reviewing 14 different interventions, including various optical spectacles and also OK keratology and also the red light and also various concentric atropine. We concluded that for cost effectiveness, number one, of course, outdoor activity is cost effective because it's costless. In a way, it is cost minimal. But we also found that 0.05% atropine seems to be one of the most cost-effective intervention in consideration of the effectiveness and also the cost. I would say red light therapy is by far the most, in regardless of the safety issue, it is by far the most effective way. But however, the cost is a bit high. And same may apply to also OK lens and also spectacles. So in terms of cost effectiveness, probably atropine is one of the cost effective methods.
Yeah, Jitendra, you had a comment to make?
I just wanted to know if we can, we can put some red filters in the glass power and tell the kids to sit outdoors for 15 minutes. Will that suffice? I mean, will it be as good as low light red therapy? To Dr. Yam.
Thank you. Thank you for the questions. The answer is I don't know, because we don't have the data. We could have a try, but probably if now we understand the red light therapy is using low energy laser, diode laser, probably using a red light filter glasses could not be replacing that method. But of course, doing so could also enlighten us more about how good for this method. We don't know. Thank you.
But Jitendra, if you can convince those children to sit out in the sun for 2 hours, then...
For 15 minutes. No, I was just saying whether it would work for 15 minutes. I mean, you can always have a LED in the house also. You can switch it on for 15 minutes in the house.
For the outdoor activity, can I ask about Amanda? That for outdoor activity, sometimes, especially I understand in Australia, it's very sunny. And some of the people may concern about that kind of skin-related cancer, even melanoma, etc. So how would you convince, especially in your locality, that outdoor activity is important? Because some of them may think otherwise.
Yeah. Yes, thank you very much for the question. It's really important to have sun protection whenever you're outdoors, and we know that very well from Australia, given our climate and the sun in Australia. But the good news about outdoor activity is that you can get high enough light intensity levels outside, even when it's early in the morning or later in the afternoon, when the UV light isn't as severe as it is in the middle of the day. And you could also get sufficient light intensity even while using sun protection. So wearing sunglasses, wearing hats, using sunscreen. So I think it's about balance, like many things with lifestyle, that you don't want to not protect from the sun, but you also need to spend sufficient time outdoors for myopia prevention.
Amanda, is there any level of illumination that is really important? So, I mean, like, dawn or dusk, because at least in India, most of the children are outdoors in the, late evenings or dusk.
Yes.
So how effective would that be? And are there any, understandings of the minimum light intensity that is required for it to be effective?
Yeah, so we don't have an exact number for the minimum light intensity, but what we think is it's somewhere in the range of 2,000 to 5,000 lux outdoors. And to give you an idea, indoor light intensity is usually around 200 to 500 lux. Outside is above 1,000 most of the times of the day, even when in the shade. So to get 2,000 to 5,000 lux, it doesn't need to be in the middle of the day. It can certainly be in the late afternoon, but the sun needs to still be up for there to be an effect. So going outside in the evening when there's very low light levels wouldn't be helpful.
And how would, you mentioned no activity per se, but would, children just reading, spending time, even if they're reading outdoors in their balcony or, in a covered area, would that, be added to the outdoor activity time or not?
Yes, we believe it would be because the activity that you're doing doesn't really matter. But obviously, if you're outdoors and reading, you would need to be doing enough outdoor time to offset the amount of reading that you're doing. So you'd still probably need some outdoor time when you weren't reading so that you could get the true effect of being outside.
One question regarding the red light therapy. Are we looking at any specific ways of detecting any side effect that comes due to the red light? Is anything done after every therapy to look for any side effect of the red light to prevent complications? Is there something that is done after each therapy to check any particular tests or done to see that the child is not going into any of these side effects or complications?
Thank you, Dr. Matalia. So what we are now doing is, number one, every time we must check the best corrected vision, and we will document the fundus picture, and we will have the OCT every time. So to look into the structural. So far, the evidence collected, the complication is very rare, I would say. In my experience, I don't have any complication at all. But of course, collectively of many cases, there should be one case report that I've presented in the study, that case report with some light damage. And after stopping the therapy, in fact, the condition reversed. The best corrected vision returned back. And so we believe that this kind of phototoxicity is reversible if we can stop it. We can identify earlier. And also that case could be suspected to be a Stargardt case, Stargardt disease, in which they have super responding to light. So we advise, we are now doing also following the others people's advice together, that we will advise to have OCT at baseline to make sure the child is normal, at least as a normal retina to start with. Thank you.
So you're doing the OCT of the macula, right?
Yes.
And I mean, I would like to ask the speakers that, I mean, each of them first, would they treat every pre-myope? And if they are planning to treat, what will be their first line of treatment?
We'll just have a comprehensive discussion on pre-myope. I think Sumita has a question, so we'll just clear that before we go on to probably, take a little bit on pre-myope. Yeah, Sumita.
No, I just wanted to ask again, Dr. Jason, is there any role for, say, baseline ERG? Because one, he felt it was staggered. And second thing, how frequently would you do OCT? Like every session of red light therapy? Or is it like, say, once in a month? Or are there any guidelines?
Thank you very much. ERG, of course, we can do that in our research protocol, in our ongoing research, we do ERG, of course. But as a clinical practice, I think doing ERG is not very practical. So I think at this moment, doing OCT and autofluorescence and also fundus picture could be good enough. But of course, if you want to really document multifocal ERG, it's also important to make sure there's no macular side effect to look into this. Thank you.
I just want one question. Continuing with that outdoor activity, Amanda, I just want to know, we don't have sun in UK for about 6 months. So would this therapy be effective there? Because another hypothesis about outdoor is probably prevents the peripheral defocus which happens during reading. So when you go outside, probably you're looking at distancing, playing. So you don't have that peripheral defocus coming on this. I just read it somewhere, so probably going to that question.
Yes, the peripheral defocus is an idea that's come up. We've got reasonably strong evidence for light intensity being important, so I think that that one is important as well. But it is an interesting idea about when you're in an area that doesn't have sunlight for large parts of the year, and we don't see prevalence rates necessary to those seasonal effects of eye growth that we see, where the rates of eye growth are much slower in the summer months and then they're bigger in the winter months, and they can offset each other. So cumulatively, if you're spending enough time outdoors during summer, then you're not getting excessive eye growth. Whereas if you're not spending any time outdoors in summer either, then you would be excessively eye growth.
So Lilian, I think we'll ask you to take the question Jyoti asked about pre-myopes. So how significant do you think pre-myopia is a risk factor? And if you treat all pre-myopes, or would there be certain other kind of indications before you start planning to treat pre-myopes as a clinical practice, not as a research proposal?
Right, Prof. So in my clinical practice, pre-myopes and even hyperopes, they do come in, and especially parents are concerned about their progression and eventually going into emmetropes as well as myopes. So we assess them based on their risk factors. For example, first we see their progression. What is their trajectory in terms of their hyperopic shift to myopic shift? And also we want to know what are their other risk factors, like are both parents myopia, or if they are high myopia to begin with, what is the lifestyle of children? Do they do sports activities, or do they are more sedentary, doing like reading as well as tablets more often? So putting all this picture together, as well as of course parental concerns, then we will come up with a management plan to decide whether we want to start this child on any myopia control treatment therapy.
Great. Jason or Amanda, any difference in the way you would approach pre-myopia coming to you?
Thank you. For pre-myope, we have analyzed our LAMP2 data and doing a secondary analysis. And of course, I fully agree with Lilian that number one, parental myopia is important. And also the how many hyperopic reserve is also important. In the LAMP2 data, we found that less than 0.75 diopter. And then it seems that atropine is helping to reduce the onset. But before that, meaning that whether you use atropine or not is still protected, because even more than 0.75, it doesn't progress a lot. So we are thinking probably 0.75 is a cutoff. For children less than 0.75, with parents, of course, is parental myopia, and also, of course, the age is also important. And then we can consider using atropine for prevention of myopia.
Amanda?
Just 1 minute. I just want to know, if you are starting atropine for that age, for that particular thing for pre-myopes, how long would you give it, and when would you decide to discontinue?
I would say I don't have the data yet. We have followed up the LAM2 data for about 4 to 5 years already, but we don't have the data. I don't know, but for my personal opinion, I will continue the treatment till the child at the age of 14 or 15 at least. So it is about it could be more than 10 years.
Oh. Jason, one more thing. So 0.75 diopters, at what age would you consider as a pre-myope?
Yes, very important. In LAM2 data is 4 to 9. 4 to 9. Of course, we don't have a more wide range. We could not tell from the data, but hyperopic reserve, age, and also parental myopia is the risk causing the more onset of myopia, and then we then find that the interaction effect takes place after it is less than 0.75 diopter.
Amanda,
it's a point. It's 0.75, as rightly said. 0.75 till 6 years, and then probably at 8 to 9 it becomes 0.5. That's how it goes.
Sorry, I missed your comment.
Yeah. No, I was just reiterating your point. That's all.
Okay, thank you.
So any comments, Jitendra? Any comments on pre-myope? Any other difference of opinion, and how you would want to tackle pre-myopes, or what you would consider as important risk factors to start?
I think what we do is that once we have a kid who we feel may go into myopia, we start telling them about environmental modifications, and if they continue despite that, so it is not the first time when they come and we suspect that this could be a pre-myope, this kid could have, he has a low hyperopic reserve. We would start accumulating data and start telling him that this thing is important. We have just started thinking about using red tinted glasses in these patients, because as such we keep telling them that they have to sit outdoors, they don't have to, obviously they don't need to get converted into myopes. So some of the patients, yes, we have started atropine and we are continuing. Around 4 to 5 patients, I do remember that we have switched over to 0.05. Yani despite giving 0.01, they are still progressing, and so we had to switch over to a higher concentration. These were earlier pre-myopes years back.
Exactly. Of course, I think every racial group, every country will have to look at their progressive cohorts. I can just quote one of our studies, which we had followed up children in the community, about 10,000 children for over 2 years. And we found that we had at that time, of course, a myopia prevalence of about 13 to 14%. And this is way back in 2013 to 15. But the more important thing I wanted to mention was the amount of children who were progressing. So we had about 30% of children who actually showed progression, and about 20% who showed more than 0.5 diopters of progression. So who were myopes in the first round we evaluated. So at least these are pre-COVID data, so I can't be sure how things have changed post-COVID. But then it's important to identify a progressor before you start intervention. And similarly, if you're looking at pre-myopes, it's important to look at the risk factors which Lilian talked about, and of course see whether they are moving towards myopia, and of course their lifestyle, which I would say would be the first way to intervene. Because again, it's important to give the most important intervention as the free easy to provide intervention of outdoor activities. So and of course lifestyle modification. So I would say that it's important to be sure before you start intervention, because as Jason pointed out, your treatment may last till 10 years. And it can be a bit of a challenge to tell parents to put one drop in both the eyes every day, day after day for 10 years. I mean, I haven't completed an antibiotic course fairly frequently, so I can understand. I mean, it can be a challenge for parents. So compliance becomes a very, very big factor. So be sure before we start intervention, because I think it's very relevant when it looks at compliance and outcomes. So yeah. So any other thoughts or any other comments, any questions
Yeah,
to take?
I would second that thought that, I mean, even when you're starting pre-myopsia, as you said, I mean, it might need to continue for years and years, and probably the important thing is the myopia progression is quite unpredictable. It's just not the same. You don't know who's going to progress, how is going to progress, even though there are risk factors. So it's with you really need to have to be sure that, yes, I have to start treatment, a pharmacological treatment for this patient, even if he's a pre-myope, because this treatment might go on for some time.
One question I had for everybody is that if we, according to the guidelines, we usually start glasses in children, in the young toddlers, only when it is high. Now, if we have a 2-year-old who has -2, do we introduce glasses at 2 years or do we wait? If parents are myopic and if parents are not myopic? Just a thought.
Refractive correction or myopia therapy?
No, refraction, normal refraction. Not, I mean, you would always start treatment only when there is progression. Here we're just looking at introducing glasses for a 2-year-old or not. If parents are myopic, parents are not myopic.
So role of refractive correction in myopia progression.
Not progression, just myopia in a child of 2-year-old.
So that's a different question. That's a different question. So that would be just refractive correction. I mean, there are a lot of guidelines for that, and for a 2-year-old child, I mean, you may, two diopters of myopia, you may probably not feel the need because his requirement is not so much, and maybe follow them up. But again, it depends upon how good, how useful you feel that, perfect vision would be for that child. So I would say that we could defer for a bit. Lilian, what would you consider?
I totally concur with you, Prof. Rohit. I think, firstly, for 2 years old with -2, we know that this is early onset of myopia. We also want to rule out any other ocular pathologies as well that is causing this -2 in a child who is supposed to be hyperopic. Then, of course, after ruling that out, we want to make sure that patient will not develop amblyopia because patient is only 2 years old, and we do know that, there is quite a number of years of runway where this child can potentially develop amblyopia, and we need to monitor these childs closely, give them a proper refractive correction, and also monitor their progression.
So I guess that, yes, Sumita, you had a point to make.
I just wanted to ask one thing, since undercorrected glasses are also a risk factor for myopia progression. I think that's what question was, what Jyoti was asking was that, whether that will actually spur the myopia progression by not withholding the glasses.
Because previously we would always follow the guidelines, but now that myopia is progressing, when a child comes at 2 years, we should introduce, not follow this, just because we know that he will eventually progress, because he's just 2 years and has -2. So I mean, that's debatable. I don't see it's like, oh, everybody can do it. You have to look at all the risk factors, lifestyle, the parents. I do get it. But then we need to really remodify these guidelines, what we have been following.
I think I would give glasses.
I think what Lilian wanted to highlight also was that at 2 years, we are not really looking at progressive childhood myopia as our primary diagnosis. It could be a syndromic myopia. It could be, some other factors like preterm. So before we start thinking that this is a definitive progressive myopia, it could just be that this is, a part of the Gaussian curve where this child is a little outlier and has a refractive error and is in the process of emetropization. Just because a child has myopia at any age, especially in the early age group, does not mean that he may not progress towards emetropization. So I think that's an important fact to remember. Follow up this child to see, and probably that's why these guidelines were in place, that if you intervene in a small refractive error, you are intervening in a process of emetropization, and you may actually halt that process and let him remain a myope all his life, or probably actually convert him to a progressive myope. So there is less evidence that you need to be so aggressive on these children. At least that's what I would say, that it's important for us to remember this, that it's not necessary all children are 100% hyperopes in their early formative years. They small percentage maybe emmetropes or maybe even myopes, mild myopes. High myopes are definitely syndromic, and mild myopes, we need to just look that up. Lilian, any comments on that?
Extremely well put across, Prof. I think you got my summarize everything very well. I totally agree with your pointers.
So I think the next team is here. Kasturi is here glaring, and she wants us to vacate this space for her. So I'll just ask Jason and Frank for some last comments before we'll say goodbye.
Maybe invite Professor Martin to have a final comment before we close this.
I'd just like to congratulate all the speakers on such an outstanding symposium. You know, I always think I know a lot about myopia, but this evening I've learnt a lot more. So thank you very much.
Thank you, Jason. Anything on behalf of the Asia Pacific?
I would like to again thank our speakers, especially Amanda, Wei-Yan, Lilian, and also our Indian colleagues. We learned a lot. So it's really a wonderful meeting, and also thanks to Rohit, who do wonderful, extremely a lot of efforts in putting everything together. And thank you, Rohit, for initiating and allow us to participate in this wonderful symposium. Thank you very much.
Thank you, Jason. Thank you, Frank, for giving us the opportunity to work with you for this wonderful Myopia Symposium. And I really look forward to meeting many of you in the APAO, and I'm sure many would love to attend the meeting at Brisbane in June, July. So thank you, everybody, and goodbye. Have a great day and a great night, Frank. All the best.
Thank you.
Thank you, everyone, for the seamless session. You guys exactly ended on perfect timing. Thank you, everyone. And we will be having the next session on periocular aesthetics, precision and perfection in the